Welcome to Pharmacy Prep. This video is about the antipsychotic drugs, and this is part 2 video. The part 1 was about the antipsychotic drugs, pathophysiology, structure-activity relationships, and also the clinical pharmacology. And now this part 2 video is about the most and the least and highs and lows of antipsychotic drugs, adverse reactions. So among them, this video is mainly focused on antipsychotic drugs' common side effects. And among these ones, mainly we'll be focusing here on the common side effects such as sedation, anticholinergic side effects, extrapyramidal side effects, and the weight gain and metabolic side effects such as diabetes and cholesterol, and then hyperprolactinemia, and also orthostatic hypotension. So these are the side effects we'll be primarily focusing on this video. So let's compare the all the antipsychotic drugs, highs and lows. And here, let me begin with first with the extrapyramidal symptoms, which is EPS. EPS is extrapyramidal symptoms. So here in this chart, which has a colored chart, so this colored chart has three colors. One is red colors, and the red color refers to the most or the high side effects, or it is preferably not recommended to use in some cases for those particular side effects. So the higher is considered as the red. And then you have another one, that's the yellow color. Yellow color is a medium side effects. And then the least side effect is a green or have no side effects. So that's a green. Green is the preferable drug for particular those patients who have higher potential of having those side effects. So in this chart, so this also as we do this in our lectures, we always also mark as a Q where there is a potential questions. So wherever there is a Q marked in this chart, I will be marking as a Q now. So wherever the Q is marked, those are the places where you expect more potential questions in the exam. Because these videos are mainly for students who are writing board exams like pharmacy board exam, medical board exams, USMLE, or NAPLEX exams. So, or NCLEX exams. So for those students who are writing board exams, there are most possible questions on the highs and the most likely side effects or the least likely side effect. Also, the questions can be given as a case scenario. Always remember, in the case scenario, you will have some other comorbidities, and then you have to look at those comorbidities, and based on that, you have to select what is the best drug for that given specific case scenarios. So therefore, let's start with this marking as a Q. And then in our pharmacy prep question bank, you have super good questions. And if you practice those questions, and that is present in our question bank at pharmacy prep, we have a greatest platform, online platform, that is Exam Prep Station. In that Exam Prep Station gives you access to the questions and also simulated mock exams. There you get an opportunity to practice those cases. For now, just to give you a refreshing high yield points where there is a more potential questions, so I will be marking as a Qs, then you expect those points. So now let's start with the first thing is EPS, because this is a very classical symptom side effect of all antipsychotic drugs. So basically all antipsychotic drugs have a one common problem, that is extrapyramidal symptoms. In short, that is also known as EPS. So EPS has four symptoms. One is a dystonia, akathisia, and also Parkinsonism, and also there is a tardive dyskinesia. Tardive dyskinesia also part of this one. So there are four symptoms grouped into this one that is called extrapyramidal symptoms. And those was been discussed in the previous video in details of the physiology of that one. So to make it quick here, in short, I would say extrapyramidal symptoms are mainly due to the D2 D2 inhibition, dopamine 2 receptors. When any drug that inhibit dopamine 2 receptors strongly likely have a higher risk of having extrapyramidal symptoms. So among those extrapyramidal symptom side effects, obviously well-known drug that has extrapyramidal symptoms are the first generation antipsychotic drugs, which is the older ones, that is known as phenothiazines. So phenothiazines are very popular drugs of first generation. At least about 8 to 10 phenothiazine drugs are present in the market. However, I just picked up here a couple of them, which is one of them is chlorpromazine. Chlorpromazine, obviously, it is a phenothiazine type of classical drug, prototype of the phenothiazines. Within phenothiazines, again, you have two groups, alkyl group, phenothiazines. So chlorpromazine falls under the alkyl group of phenothiazine class of drug. So this chlorpromazine, first generation, obviously it is considered as a low potency dopamine inhibitor, or it binds to the low potency, less potency of dopamine receptors. However, it has a higher binding to those histamine and also anticholinergics. So for that reason, the low potency first generation antipsychotics generally considered as less or moderate type of extrapyramidal symptoms. And within those phenothiazine, there is a piperazine type of phenothiazine, which is a fluphenazine. Fluphenazine is considered as a high potency D2 receptor antagonist. That means it has a strong binding to the D2 receptors, and as a result of that, it goes under the category of high potency, strong inhibition of D2 receptors. So as a result of that, this high potency antipsychotic drugs are known to have a very higher extrapyramidal symptoms. So therefore, these drugs are known for high extrapyramidal symptoms. And also within the same, haloperidol. Haloperidol is another important drug that is known for stronger high potency drug. So eventually, haloperidol has higher risk of extrapyramidal symptoms. So there is a comparison data studies have done to show within the extrapyramidal symptoms, especially tardive dyskinesia. Tardive dyskinesia has a higher tardive dyskinesia, which is about 5 to 5.5% of tardive dyskinesia for first generation antipsychotic compared to second generation. Second generation has a less extrapyramidal symptoms, which is considered as especially compared with the tardive dyskinesia. Tardive dyskinesia is one of the extrapyramidal symptoms, which is involuntary movements of chewing motions, etc. So those symptoms are less common, which is 3.9% compared to the first generation antipsychotic drugs. So that means, in summary, if you ask me about antipsychotic drugs, first generation high potency drugs such as fluphenazine and haloperidol have higher extrapyramidal symptoms. So here I like to mark as a Q. There's a potential question. Haloperidol, which is a butyrophenone type of antipsychotic drugs, considered as a higher potency drug, and therefore it may have higher extrapyramidal symptoms. So therefore, in the case scenario, also the management of these extrapyramidal symptoms, if patient is taking haloperidol and experiencing extrapyramidal symptom, the best management is to changing to the second generation antipsychotic drugs, such as all these drugs here are second generation drugs such as Clozapine, Olanzapine, quetiapines, and also the new ones, also partial other drugs are less common extrapyramidal. Especially if you ask me, the Clozapine can be a good option, although Clozapine is only used for resistant type of psychosis. That means it is not used as a first-line choice for the first-time psychotic patients. However, one can use Olanzapine and quetiapine are least likely EPS side effects. So if you have a case scenario question asking patient is experiencing EPS and now prescriber considering to switch to a other antipsychotic drug, so what drug would you suggest, advise to or recommend to use to minimize the risk of extrapyramidal symptoms? So you can choose one of the drugs from the second generation based on the other factors, because selection of the drug for psychosis depends on drug side effects and also patient-specific conditions. And therefore, there is Olanzapine can be a good option, which has a considered the least extrapyramidal symptoms, and also quetiapine can be a good option. So if you're otherwise, you also have to look at the other comorbidities, because Olanzapine and quetiapine can have other problems, which is, I will discuss that in a minute, which is especially weight gain and metabolic side effects. So if person is experienced already have a overweight and also have a high cholesterol or diabetes, then eventually the Olanzapine is not a good option. Quetiapine also not a great option. Then you can choose any of the new drugs which are less likely can be associated with those metabolic and also weight gain side effects. So therefore, selection of the drug depends on the patient's specific conditions in the case scenarios you would be doing it. Good. So that's about the extrapyramidal symptoms. Although extrapyramidal or EPS are less common in second generation, but there are serotonin direct selective dopamine antagonist or type of um, second generation antipsychotic, especially risperidone and paliperidone, known to have extrapyramidal symptoms. Especially, it is a moderate category. It's not very high. It's a moderate type. So I like to mark as a Q here. So Q means there is a potential question, especially in the risperidone. It has a akathisia. Akathisia is one of the EPS symptom. So akathisia is like a restlessness. A person cannot stay still or cannot always feel like moving or crawling out of their skin. So that kind of symptoms are seen with risperidone, or also which is a paliperidone, which is a metabolite of risperidone, which is also has a similar akathisia side effects compared to the other second generation. So therefore, if you're looking for a second generation that are known to have EPS, remember risperidone and paliperidone, both of them, they are similar in terms of their structurally, they're related to them, except small difference in their chemical structure. So they belongs to the same chemical class of the drugs. So these two drugs have those, so therefore that is a potential question is possible from risperidone and paliperidone. So this is the summary. So in summary, EPS are higher for first generation, especially for fluphenazine and also haloperidol. These two are big ones, whereas second generations are preferable. These three are preferable for low risk of EPS. However, if you're using risperidone, paliperidone, there is chances of having akathisia. So therefore, this is not a good option. Including aripiprazole also have a moderate type of akathisia side effect. So therefore, these three drugs may be less likely selected. Instead, you can select any of the other drugs, which is not mentioned anything here. So this is a summary of EPS. So if there's a question on the EPS management, change to the drug that is least likely can cause extrapyramidal symptoms. That's the best option. Good. So the next one is about the sedation side effects. So among the sedations, which is interesting, is this sedation comes due to the histaminic receptor H1 antagonistic effect. So stronger the drugs they bind to the H1 receptor are more potency drugs, or the drug that are bind to the more histaminic receptor, eventually they can lead to the drowsy and sedation side effects. So among them, in the first generation, which is chlorpromazine or phenothiazines, basically pretty much all phenothiazines, especially low potency phenothiazines such as chlorpromazine, promethazine, methochlorpromazine, like those are all good examples of first generation phenothiazine type of drugs, and they have a stronger effect on H1 receptors, and therefore they do have a less effect on they causes the more sedative effect. So that's in the first generation. Compared to the stronger potency drugs such as haloperidol, phenofluphenazines are known for less sedation side effects. So that's a so just keep in mind Q for chlorpromazine question is potential possible in first generation. So next one is about the in the second generation, especially the multi active receptor antagonist type of second generation antipsychotic drugs. So clozapine has a higher sedation, and also olanzapine and quetiapine, they both have this sedative effect. So especially quetiapine can be causing much sedation, therefore have to be gradually titrate the dose some cases. So all you have to know here is the Q for this type of drugs such as clozapine, olanzapine. It is always good idea to give at bedtime. There's a reason that's given at bedtime, just mark as a QHS. So again, there could be a case scenario, patient could be presenting with concern that patient is unable to work daytime because patient is taking, let's say, quetiapine in the morning daily. So eventually patient unable to work and feeling sleepy all the day. I cannot focus on the work, cannot give attention to the work. So in that case, it is good idea to switch on this medication patient taking at bedtime. That's the best management. Remember, you may have a question, direct questions asking about what drug has the more problem or what patient could be experiencing. You will be given a case scenario and you will be asked what patient could be experiencing. In that case, if question is about that, then you can select any of these three drugs if patient taking them. Or patient could be coming, especially it can happen in your practical exams like OSCE exams. So a patient is coming and coming with the concern, and patient daily takes quetiapine in the morning. And since he started taking quetiapine, he is not able to work, pay attention on the work, feel like all the day sleepy. So in that case, one can switch the drug to the bedtime. That's the first step in management of them. And also, if it is not tolerable, despite changing them, then eventually patient have to be switched to the other drug that has less sedation side effect, which is all these other drugs, especially aripiprazole and brexpiprazole. If you're switching, maybe these two drugs have a very low sedation side effect. Again, I mark as a Q here. These two drugs have a very low sedation side effect. So if you're switching to them, that could be a good switch. So I would switch to the aripiprazole or brexpiprazole in case if patient cannot tolerate sedation side effect with olanzapine or quetiapine. Of course, clozapine as well, but clozapine generally reserved for resistant type of psychosis therapy. So that's it. In summary, if you're switching from olanzapine to quetiapine, switch to aripiprazole or brexpiprazole in case if patient is experiencing severe sedation and cannot tolerate taking this medication. Just to make you cue here, Also remember the low dose of Clozapine also used for insomnia treatment because of this nature of its side effect, which is a sedation side effect. That could be another cue there. That's important to remember that one. And then comes to the next side effect. So in summary, sorry, before I go to the next side effect, in sedation, the higher is chlorpromazine, and these three drugs have a higher sedation, so better give it bedtime, or if not, change to the drug that is better drugs such as aripiprazole or brexpiprazole. That's the best management for changing sedation. So next comes to the weight gain side effect. Weight gain is the big one, which can be very concerning for some patients, especially that is weight gain is known to cause by histaminic receptors and also serotonin receptors affect this drug, the drug that is affecting on serotonin, especially 5-HT2A. Since 5-HT2A effect is less on this drug, first generation drugs, therefore you see first generation drugs have very little or none weight gain side effect. So when it comes to the second generation drugs, such as highest weight gain is associated with the Clozapine and Olanzapine. These two drugs have a very high weight gain side effect, whereas Clozapine has a moderate a medium side effect. But when it comes to the now you have a patient who is overweight and now started taking this medication past 3 months, and patient have gained weight, and now patient has a concern and prescriber wish to switch to the less weight gain drug. So what would you recommend it in that case? So in that case, you can choose any of these drugs, such as ziprasidone can be a less weight gain. Here, this green means no, at our least or none. So asenapine can be a good option, or aripiprazole or brexpiprazole. These four drugs are known to have a very low weight gain or no weight gain at all. So therefore, these can be a good options for patients who are experiencing weight gain with any of these second generation antipsychotic drugs. So that's a good management for the weight gain. And also there are generally, if patient has more than 7% of the weight gain, then eventually requires some drug management for the weight gain side effect of the drug. And also lifestyle modification. Pharmacist counseling can involve lifestyle modification to reduce the diet, and lifestyle modification can help to reduce the weight gain issues that could be associated with the milder form of weight gain from these second generation antipsychotic drugs. So in summary, the highest weight gain or the most weight gain is from these two drugs like Clozapine, Olanzapine Q, and then the more important here is the least weight gain side effect drugs. So these four drugs I would consider as the least weight gain side effect, especially the new ones, which is the D2 partial agonist drugs, such as aripiprazole and brexpiprazole. Those could be a good option for least weight gain. Next comes to the anticholinergic side effects. Anticholinergic side effects are associated with the muscarinic receptors, M1 receptors, or so M1 muscarinic receptors inhibition lead to the anticholinergic side effects. So the anticholinergic side effects are moderate for chlorpromazine, but the preferable drug for anticholinergic in the first generation is haloperidol. Just remember that one. Haloperidol has the least muscarinic effect in first generation. So therefore, that's could be a good option for anticholinergic person. Like among the anticholinergics, obviously patient may be experiencing constipation and dry mouth. These two are the big ones that is commonly seen due to the muscarinic receptors inhibition. So constipation and dry mouth. So these two effects are more common. And if person is experiencing, that can be managed. If not manageable, not tolerable, then you can switch to the drug that has the least anticholinergic side effects. So among those first generation, the haloperidol has the least, whereas second generation, only these two drugs, Clozapine, Olanzapine, has a higher side effects. So therefore that you have to keep in mind. But remember, that's an interesting thing is Clozapine also has a hypersalivation side effect. Nearly 30 to 40% of side effect of Clozapine is hypersalivation. That means you may not see the dry mouth, but there can be a constipation type of anticholinergic side effect possible with Clozapine because of that hypersalivation side effect of Clozapine. Whereas Olanzapine can have the constipation and dry mouth in terms of their medium level of side effects. But if it is not tolerable, then one can switch to any of these second generation. That's a good option for switching if it is not tolerated. Well, the next side effect or metabolic side effect. Metabolic side effect include two major problems. One is a diabetes mellitus, and then increase in cholesterol, especially LDL and triglyceride. These two things are part of the metabolic side effects. So metabolic side effects also known to cause by the 5-HT2 effect. So therefore, first generation, none of them has any high level or medium type of metabolic side effect. Metabolic side effects are common with these two drugs, which is red here. Clozapine has a higher metabolic side effect, and also Olanzapine has a high metabolic side effect. So these are the two side effects or metabolic side effects. So these are considered as high metabolic side effects. So therefore, this would be considered as a less preferable drug, especially if you have a patient with comorbidity with diabetes and also high cholesterol, high LDL or total cholesterol. The best drug to avoid is Olanzapine. Olanzapine is the best answer. That's your answer to go. Whenever you have a patient comorbidities, the best answer to choose is second generation ones is Olanzapine. Olanzapine doesn't fit in those because of that a high metabolic and high weight gain side effect, and also has a moderate anticholinergic and also sedation side effect. So therefore, that could be a least option if you have to select for person with the higher or a person with the higher diabetes or LDL or comorbid condition case scenario. Generally given case scenario can be a long case scenario, but you aim to answer for avoid Olanzapine. So if you're avoiding Olanzapine, then what drug can be better option for that? Even Clozapine also has a moderate metabolic. These three drugs, such as a multi-receptor, multi-acting receptors antagonist, are considered as a higher metabolic side effect that include diabetes and high cholesterol. So therefore, they also require monitoring of those cholesterol and blood glucose levels. Then if you are switching from these three drugs to some other drug from the second generation, what would you select it for patients who have diabetes and cholesterol? If you're selecting, then maybe you can start with the D2 partial agonist. They can be better option because they have least. Aripiprazole can be best answer, or brexpiprazole can be best answer. Those are the considered as the least metabolic side effects, which is cholesterol and also diabetes. Also remember, they also have a least weight gain and also have a less sedation. Just slightly aripiprazole has some akathisia side effect. Otherwise, they are good options for patients who have diabetes and also high cholesterol. Aripiprazole can be a best option. Next comes to the important side effect, which is a QT prolongation. QT prolongation side effect is very interesting, which has been much more data now. Recently, you have a lot more information on QT prolongation. The best reference is for the QT prolongation is the incredible drugs reference is the can be a good option to look in for that one. So among the QT prolongation, maybe you're aware that early 2000s, in 2005 or so, thioridazine, which is the first generation antipsychotic drug type of phenothiazines, they are taken off from the market, withdrawn from the market, because that has the highest QT prolongation. Obviously, the QT prolongation is ventricular prolongation time. So generally, normal time for QT interval is about 400 milliseconds. However, on top of the 400 milliseconds, if this drug adds 30, like thioridazine is known to have a 30 milliseconds of QT time interval prolongation. So that means it is considered as a very high QT interval prolongation. That's the reason these drugs are withdrawn from the market. So generally don't expect questions on the drug withdrawn, but if it is withdrawn recently, then you may have sometime questions in the exam why these drugs have been withdrawn. But at least you should know the history of the thioridazines, which is known for very high cardiovascular side effect, which is mainly QT interval prolongation. So you also know that QT interval prolongation lead to the condition called Torsion Dependence, which sounds like a French word, right? That is true. That's a French word. What that means is twisted waves. So therefore, this has been studied like in mid of the 1960s or so on, and 1990 it has become a lot more obvious, and many drugs known to cause QT prolongations. So among the drugs, there are some class of drugs are known to have a very high QT prolongation. Obviously, among those QT prolongation drugs are the more common ones are antiarrhythmic drug itself, like for example, sodium ion channel blockers, potassium ion channel blockers like amiodarone and etc. They are known to have a pretty high. Basically, QT prolongation is measured in milliseconds. So generally, 30 milliseconds are considered as a very high. So therefore, and if person is experiencing more than 500 milliseconds, the drug have to be changed. So that is what recommendation according to the QT interval prolongation recommendations. So therefore, since antipsychotics are one of the class of drug that is known to have a higher QT prolongations along with other drugs, class of drugs such as antiarrhythmic drugs and also antibiotics such as macrolides and also drugs such as fluoroquinolones, they're also known for higher. So especially any drug that has a QT prolongation, better to avoid another drug that also has a QT prolongation side effect. So if you're going for any of these drugs here that has a QT prolongation, whenever you're adding other drug that is known to cause QT interval prolongation, definitely it is not a good option to combine because that can increase the chance of higher QT interval prolongation. So therefore that required careful selection of the drug in the questions and answers. So in simple words, if you ask me what drugs have the highest QT prolongation in among all antipsychotic drugs, I know since it is withdrawn, so no, I'm not talking about thioridazine, that is the highest, of course, but in second generation, ziprasidone has the highest QT prolongation. So I'm going to mark as a Q here. That means there is a more potential question. So ziprasidone has about 15.9 milliseconds. So that is almost 16 milliseconds, which is pretty high compared to other drugs. Second highest drug is haloperidol, which is 7.1 milliseconds. That's considered as also higher. Whereas the least, if you ask question, what drug would you choose for a person who have a higher risk of QT prolongation? Because QT interval prolongation also can be potentiated by other risk factors, like person has a congenital QT prolongation, then it can also increase the risk of more QT prolongation that can be added if you add this drug, or age. And also, surprisingly, female has a higher risk of QT prolongation compared to the men. So that means there are the risk factors like old age, female gender, and also persons with the congenital QT prolongation history. So these are the factors that can increase the risk of QT prolongation. So whenever you're adding these drugs, especially if you're choosing ziprasidone, for all those cases, it is not a good option. And if you're looking for the best drug, you're looking for the least QT prolongation drug compared to this one. Excuse me, Olanzapine. Olanzapine can be a good option to select for patients who have risk of QT prolongation. Again, this red point doesn't mean they are contraindication. Don't consider that as a no drugs. No, it is not about contraindication. It's about it is a most, least, or high and lows. This is a very special topic. We do have our clinical pharmacology book. In our clinical pharmacology published at Pharmacy Prep is amazing source of this kind of information for the highs and lows of this information. So therefore, I would strongly recommend to follow clinical pharmacology reference book that is published at our Pharmacy Prep. So this kind of comparison can be helpful to remember. So the highest is ziprasidone, the least is olanzapine. Whereas other drugs also have a slightly, like aripiprazole has about 3.9, almost 4 milliseconds of QT prolongation. So therefore, that could be not a good option if you're adding with other drugs. And also, quetiapine also has it, but I haven't added the number here. But quetiapine also has a certain amount of QT prolongation. Also remember, if you're, especially if generally case scenario could be, do you remember this medication like quetiapine can be also used for bipolar depression, bipolar manic disorders. So in that case, if person is already taking other medications, then you have to watch for other drugs that QT prolongation as well. Or if this is also used for resistant type of depression, then in that case, if patient is taking citalopram, which is known to have a very high QT prolongation in SSRIs antidepressants, then if you're adding quetiapine with citalopram, definitely is a no good combination. That means that can higher risk of. Or if your patient taking ziprasidone with escitalopram, definitely it's not a good option to combine. So that's the one you should keep in mind that is considered as higher risk of QT prolongations. So this is and finally the QT prolongation points are the highest QT prolongation with mark as a ziprasidone Q, least is olanzapine. Those two are the good point. If you're looking in the first generation, haloperidol is considered as the highest QT prolongation drug in this class. Also, chlorpromazine also has it, so it is considered as a higher as well. So therefore, those are the few summary on QT prolongation. Good. So with this QT prolongation, next we have another cardiovascular problem, that is blood pressure, which is also known as orthostatic hypotension. What that means is these drugs, they also affect on alpha-1A receptors. And this alpha-1, when they inhibit the alpha-1, so alpha-1s are vascular constrictors. Eventually, now you're inhibiting them, so that can lead to the vascular dilation. So, and that lead to the low blood pressure. And the blood pressure, whenever falls down less than 20 units, like mercury of less than 20, and heart rate can go up to 25 beats per minute, more than 25 beats per minute. And that condition is known as orthostatic hypotension. And among those orthostatic hypotension drugs, the medium drugs include the first generation, such as low potency drugs, phenothiazines. They have orthostatic hypertension. And also remember multi-acting receptor type of antipsychotics, such as Clozapine and Olanzapine and Clozapine, they also known to have orthostatic hypotension because of the severe effect on alpha-1 receptors. And among these second generations, this applies to, this has to be applies to the aripiprazole. This is for aripiprazole. Just require correction here. Doesn't match the line, but it is for aripiprazole. So remember this side effect is for aripiprazole. So aripiprazole also has effect on alpha-1 receptors, eventually can lead to the orthostatic hypotension. So these are the drugs require monitoring, especially let's say if someone is taking Clozapine and now suddenly it can feel person can get dizzy. That means person, maybe the initial dose could be high. So the dose titration for these drugs require careful titration because otherwise it can start more low blood pressure and can make person dizzy and fainting, which is sometimes also known as syncope. So therefore, those are the key points. So in summary, question can be, what is that receptor causing orthostatic hypotension? Alpha-1 receptors inhibition leading to orthostatic hypertension. So that direct question is possible. Or if you're going with the Clozapine, if patient is experiencing those sudden low blood pressure or dizzy, fainting because of the low blood pressure, then maybe the dose titration require gradual titration. Go slow, and then increase the dose. So that could be one of the reasons. So otherwise, if patient is not tolerating at all, then you can switch to the other drugs that are none of them. Most of them have very little or none orthostatic hypotension. Therefore, those can be a good option. Good. So next comes to the other side effect is about the prolactin, hyperprolactinemia. Hyperprolactinemia is coming due to the D2 inhibition. When you decrease D2 receptor, significantly decrease, then eventually can lead to the increase in prolactin in the blood and prolactin formation. That means that is also known as hyperprolactinemia, or also known as galactaria. Sounds like a rhea, like a diarrhea. So it is kind of galactaria. So these galactarias are D2 or coming because of the D2 receptors. And so it is chlorpromazine of low potency drugs also has a pretty high prolactinemia. Flufenazine is considered as a higher prolactin. And the first generation, obviously, they are stronger binding drugs to D2. They do have eventually higher hyperprolactinemia. It doesn't mean that second generation doesn't have it. Second generation, especially risperidone, just mark as a Q. Risperidone has a higher hyperprolactinemia side effect, and its metabolite paliperidone also has higher hyperprolactinemia side effects. So these two drugs in the second generation are known to cause hyperprolactinemia side effect. Remember, the drugs that is causing the hyperprolactinemia, they do also decrease the production of follicular stimulating hormone, FSH, and eventually that FSH also decreases, and it can lead to the amenorrhea in women. So therefore, could be an additional point along with the hyperprolactinemia. The relation of the prolactin to dopamine to follicular stimulating hormones. So the next is finally we have some other rare side effects, but serious ones, especially clozapine, which is a very frequent question. Clozapine has serious agranulocytosis. Agranulocytosis is a very significantly decrease in white blood cells. So that's the reason why clozapine require once a week blood test, lab work have to be done before patient gets another week medication. It is a very serious condition. although it's rare, but can be seriously can cause harm to the patient. Sometimes question could be monitoring. Direct question: what do you monitor? You monitor white blood count, or question could be related to what. Sometimes there is answers where patient may be experiencing flu-like symptom like fever, cold, and cough especially, and feverish. That means there is an increased risk of infection. Whenever there is a neutropenia, person become more likely prone to get infection. So therefore, there are other ways question and can be presented in the exams. So for that reason, you have to really look into the details. Always remember, whenever you see clozapine, think about agranulocytosis, which is a mainly neutropenia side effect. And for that reason, why clozapine is only used reserved cases for those who will the resistant type, means someone who is not treated by other antipsychotic drug, then clozapine can be a good option. So, so therefore, that could be a considered as a good option. And then it comes to the other rare side effect, which is the interesting ones. There is no reason to explain how that happens, mechanism for it, but there is a paliperidone has a slightly insomnia side effect, and also aripiprazole also has insomnia side effect. In case the patient is not tolerating, don't give it bedtime, give it in the morning hours. So that could be a good option. So these are the summaries of the most common side effects, adverse reactions of antipsychotic drugs. So with this summary of this antipsychotic adverse reactions, and we do have a great cases and questions that is presented in pharmacy prep question bank. And those students who are enrolled in our prep courses, they will get access to that program, and you will have a great practice to that one. So I really thank you for your time, and also I really appreciate if you can subscribe our YouTube channel. That is, my name is Misbah Biabani. And also, if you have any questions, you'd like to know more about this, you can also make a comment, or also you can email us at our email address success@pharmacyprep.com, or also you can send us the text on this number 416-223-7737. And finally, I thank you and look forward to hear more videos on the highs and lows and the most and least adverse reactions of the drug and clinical pharmacology topics, and also pathophysiology topics. Thank you again.